Okay, let's begin then. A very good evening, good morning, depending on the time zones you are in. And I'll just start my screen. So I am Dr. Anurag Mishra, and on behalf of Collaborative for Innovation in Rural Surgery, I welcome you all on this workshop on innovation for minimal access surgery in low resource setting. So just to introduce who we are, Collaboration for Innovation in Rural Surgery, or CIRS. It's a global multidisciplinary collaborative platform which aims to make available a low cost but high quality surgical services accessible to all. And it tries to use the principles of collaboration and frugal innovation to solve the problems faced by surgeons and at a broader level, the people of rural areas. So as we say that we are people with different skills, but we are united by a common vision. So this is CIRS. And today we are holding this workshop, which is on innovation for minimal access surgery. The goal of this workshop is to understand the unmet needs faced by rural surgeons. We will try to introduce skills in a very brief format. And also the major aim of this workshop is to explore the potential for future collaborations and in the area of innovation, which aims at to enhancing the access of surgical services. So some ground rules for the participants. Please keep yourself on mute while you're not speaking. Whenever you want to speak something, please raise your hands, or you can write your comments, questions, feedbacks on the chat box. The questions generally will be taken at the end of the session and not after each talk. So just to save time. And at the end of the session, the moderator will take your questions and discuss them. Otherwise, if there is a paucity of time, we will make sure that the questions are answered and the replies are sent back to you by emails. So let's stick to them. Without much ado, I think I will set the ball rolling, and I will invite uh, Mr. Noel Ruparayel. He's one of the most important key member, I think, who's started the whole study around gills and gasless work. He's currently working with University of Leeds as a so he was also a past president of GASOC. He is one of the member of G4 Alliance Permanent Council, and his expertise in minimal invasive abdominal surgery, and also happens to be the lead investigator of the GILS project. Noel, over to you.
Thanks very much, Anurag, and warm welcome to everybody who has just joined our workshop. So without further ado, we would like to hear from our rural surgeons who have been part of this project. Some of them have been part of the training program, and some of them are going to be part of the training program or leading the training program. So we have got three key surgeons coming from sort of three different areas. First, I'd like to introduce all of them first of all, and then get them to present for the next 5 minutes, and we'll have a few minutes at the end of their presentations to discuss. Here they'll share about their current practices and how minimal access surgery has been important in their clinical practice. So our first presenter is Dr. Biju Isleri. He is an MBBS MS FIAGS surgeon who is part of the target training program, who is currently working as a general surgeon at Crofts Memorial Hospital in Assam, India. Our second presenter is Dr. Elijah Mwara. He's a surgeon from Kenya in East Africa, and he's learning minimal access surgery to enhance his skills and able to share knowledge at his local place. And our third presenter is Dr. Jesudian Ganaraj, who is an accomplished urologist and laparoscopic surgeon and the in-country lead for gasless laparoscopy. He's a past president of Association of Rural Surgeons of India and has dedicated his entire life to improve access to surgical care in rural setting. So I would like to welcome Dr. Biju Slurry to start with his presentation, and then we'll follow up with our next presenters after that.
Hello, everyone. How do I do that screen sharing?
So just at the bottom of the screen, Dr. Biju, there is something called share screen. So you can just click that, and that should be able to bring your PowerPoint presentation.
Is that working?
Yeah, we can't see your slides at the moment.
Biju, you want me to play your slides?
Yeah, I think so. I'm not able to.
Okay, so just end your screen sharing. Okay, just a second.
I think I have this one.
Yes.
Okay.
Yes, I think it's coming now. I can see it.
I think you can start.
Yeah. Is this from mine or from your screen?
It is my screen.
I think I have changed many things.
Okay, so
Like to.
just a second. You can quickly try.
Yeah. Is it coming?
Yeah, we can see it now.
You can see the screen?
Yes, we can see your screen.
Okay.
Go for it, Dr. Biju. Thank you very much.
Yeah. My introduction has already been said. Thank you, Dr. Nail. I am Dr. Biju Islari, currently working as a general surgeon in Crofts Memorial Hospital. This is the red dot is where I am situated at. It's very close to Bhutan, Indo-Bhutan border. And this is a small Christian mission hospital. So we are catering to the rural population. We are actually at the rural, purely at the rural place. So when we discuss about the unmet needs of the rural population, I'd like to just look at from two perspectives, maybe one from a rural population itself, and then another from the health care provider side. So on the population side, since we are catering mostly to the rural population as we are situated at a rural place, I would like to highlight a few of the things that the rural population face when they get when they need to come to a hospital also. First and foremost is they are very poor. They come from a very poor socioeconomic status. So, and most of them are daily wage earners, and many of them are farmers. There are only few who holds the government jobs, but it is, I would like to say, it is the place where the poor people live in. So If they don't do anything for one day, they're not going to get the meal for the next meal. It's like this. So this is very important to understand. First thing is to understand the population where we are working. So following sick or going to the hospital is very expensive for them. Say if it is surgery, it'll be really a difficult one. So now if they have to go to a hospital, they will think twice. Should I go to a regular pharmacy, over-the-counter drug that I get some paracetamol or some painkillers or some over-the-counter antibiotics and all? They'll first use those things rather than coming to the hospital. So they want to save the money, and they don't have money also, because when they come to a hospital, it'll be like they have to spend for the registration, consultation fee, another few more bucks they have to spend. But when they go directly to a small pharmacy in a shop, they just need to pay the medicine bill and then take the medicine and take 2-3 pills, whether they get well or not. Now, when it is a surgery, it's like they'll try to keep back. If they have a surgical problem, they will still say, I'll take few more medicines, it'll work or not, I'll wait for some time, I'll take few more medicines, wait for some time, until and unless they are in a very deep situation, that until and unless they go to a hospital, they'll not be surviving. When they come in such a state, because they do not have money to come at the proper time. That is one thing. And when they have to come, they come, they'll ask, how much will it cost? How is it? How many days I have to stay in a hospital? That is very important. They want to know. And then when we tell them that this surgery will cost this much, this procedure will cost this much, they'll start asking, like, shall I stay a few more days so that I can accumulate some more money to pay for these bills, which is very difficult for them. In case of emergencies, they do not have any other way. They have to sell their livestock, even land and all, to meet the medical or surgical expenses. This is how this kind of people we are meeting every day in our OPD. Every day we cater to. And a few things I would like to speak from the healthcare providers side, from a rural hospital, because I'm working in a rural hospital from the first place after coming from my post-graduation. So this is the hospital, that Crofts Memorial Hospital. Sitting here in this hospital and then working, I have seen many things, but I would like to share only few things which are important, and then would like to address for this if it is possible. From our side, healthcare providers sides, people living in city and then working in some corporate hospitals, and then the bigger hospitals may not understand what we face usually and then regularly in rural setup, in a very small hospital where there are only few beds and no doctors, no other support staffs, like this. So most of the rural hospitals are small hospitals with few beds, and we find shortage of doctors. There will be very few specialists or no specialists at all. Trained nursing staffs, that is also very far to think of. It'll be just untrained people most of the time, or they have the degree but they're not good, or they do not know what to do, or they are not well trained, I should say. And other support staffs are also very few, because it involves paying salary to them, taking care of these payments, it's difficult to take more and more number of staffs. That is one of the major setbacks that keep smaller hospitals or rural hospitals difficult. Another thing is a diagnostic lab. Uh, we may not get many or a good diagnostic labs in our rural setup. Some basic diagnostic labs may be available. The high-end diagnostic facilities may not be available. And say imaging facilities, it's also very rare. We may not get every time. Another thing is uh, power supply. The power supply very interrupted. You will not get any constant power supply, and without power, can't do anything. It's very costly to get other backup for powers also. Another thing is autoclaving facilities. It's also difficult to get in a rural setup. So seeing all these things, I would like to say a few things. In our setup, what I faced, including whatever I have said, um, we did not have surgical facilities before in Crofts Memorial Hospital before I joined. So it became a very big challenge for me to start the surgical work there. It was really difficult. The reasons are very obvious. I should say, number one, being a surgeon, without anesthesiologist, we can't do any surgery. Without surgical equipments, no one can do any procedure. Say for a laparoscopy, we do not have laparoscopy sets and autoclaves. Now we have, earlier we did not have, and trained staffs. That is one thing. And then financial constraints. This is the main thing. We want to get many things, but finances hold us back. We cannot go more, or like we cannot take big steps to get better OT or surgical equipments. At present also, till now, after 4 or 5 years of work, I'm not able to purchase even a laparoscopy set in our setup. So the laparoscopy set that I am using right now is kept by Dr. Gyanraj. So, and that is also working, and I'm using it. And I thank Dr. Gyanraj for lending this equipment to use. And just to use this, I was introduced to target study. I'm one of the trainees, and we got trained. We had 3 training programs, and the final program is also over. So at present, I have been doing laparoscopic surgery in our setup, including open surgery cases. And laparoscopic surgery is divided into 2. One is gasless, another is with conventional gas laparoscopic surgery. Most of the surgeries that I have done here is gasless laparoscopic surgery. Around half of what gasless is, I have performed with gas. So twice gasless, and one like half is with gas. So the most important thing that gave me to do is this gasless, because it is difficult to get the gas also. And since last 2 years, I have not been able to finish one full tank of carbon dioxide gas till now. It's still lying, and I have not finished it. So it's only the gasless which is helping me to work more and more, and I'm happy to work with that. So this is one of the pictures that in my initial days I did with 3 more staff nurses, and I'm the only surgeon here. And in our hospital, I am the only surgeon. There are no other specialists, and one MBBS doctor is there. So we are doing with this few staffs and then difficult working setup we are doing. This is the GILS apparatus that I am using in this operation. That is lab cholecystectomy, gasless lab cholecystectomy operation that I was doing. I used to call anesthesiologist on call. Whenever he gets time, he would come and help me in the surgery. And that's my short uh, speech for this program. Thank you all. This is our hospital. Very small setup.
Thank you very much, Dr. Bijoy Slary, for this wonderful presentation. And I had the privilege to visit your lovely hospital as well at Cross Memorial Hospital. Very fond memories of this place. Really appreciate you taking time and speak at this international stage and share your experience. It's been a great privilege for all of us to hear your experiences, and hopefully you can stay with us for any questions later on. I will request Dr. Mora to upload his PowerPoint presentation, please, and share his perspective in the rural parts of Kenya where he's been operating. Thank you.
You're all able to see my screen, I hope?
Yes, we can. Thank you.
All right. So my name is Dr. Elijah Mora. My hospital, it's a faith-based hospital by the name PCA Chogoria Hospital. PCA because it's Presbyterian, Church of East Africa. And I am the head of the surgical unit at the hospital, and I'm a program director. We have a surgical training for general surgery there under COSEXA. COSEXA, which stands for College of Surgeons of East, Central, and Southern Africa. I was trained as a general surgeon in Kenya, and for laparoscopy, I didn't do that in my undergrad. I mean, in my general surgery training. So I needed to train a bit more, and so I had my training in Netherlands at Amsterdam Skill Center and VUMC, which is a medical university. I've worked as a surgeon 6 years at Chogoria. Chogoria is 200 kilometers from Nairobi. Nairobi is our capital city. And I've been involved with Professor Jani at OTPAC and COSEXA to try to, in activism, basically to create opportunities for laparoscopic training in Kenya and equipment. So one of the push for us to try to improve laparoscopy landscape in Kenya is because if you look at this graph, so Kenya sets the pace for most of the African countries around it. And if you can see there, this is a comparison of the countries that are surround us, comparing hospitals and number of surgeons that claim to be comfortable doing laparoscopic surgery. So you can see Kenya seems to be doing well, but in actual sense, this is the raw data for Kenya. You see, we only have like 200 surgeons and gynecologists who can say they are comfortable with laparoscopic cases. Out of this, 3/4 are in Nairobi, which is the capital city, and only 50 are in the rural areas. From the suppliers, the main suppliers of laparoscopy towers in Kenya, there are only 32 hospitals out of a registered 5,500 that have laparoscopy towers. From a study that was published in the Journal of Endoscopy in 2020, Journal of Surgical Endoscopy in 2020, there were the perceived barriers to laparoscopic surgery were put forth as shown in the image there. And poor access to training equipment was the biggest of them. Poor access to mentors, poor access to laparoscopic equipment, cost of laparoscopic equipment, and maintenance that comes with laparoscopic equipment are the key things that deter people from having this all over. Then the rest of the factors listed there deserve to be mentioned, but they are not as great as the five I've just mentioned. So laparoscopy training in Kenya is such that most of the surgeons currently who need to do laparoscopy have to pursue it after general surgery training. There are no formal programs in the country as of yet, so most have to look outside the country in order to acquire that skill. And that COVID has complicated since 2020 when COVID hit. Few have had to travel out of the country, but seems like things might be opening up recently, although with challenges as well. So that's myself when I was in Amsterdam doing my training. So I had both hands-on training on dummies and on in a wet lab, on cadavers, as well as observership at a hospital. So what's the way forward? Way forward is we've tried to have local trainings, but we've had to improvise boxes, as you can see in the image there. We once had a 3-day workshop for training surgeons with time scoring for the 5 tasks for foundation in laparoscopic training to decide on competency of the surgeons that attended the training program. This was we had studied what happened at the target study, and so that's what we tried to work with for this. We've also had some digital training. We in collaboration with from my visit in Amsterdam Skills Center, we developed an online training that the skill center supplied us with some boxes, as shown on the image there. We had trainers from there, and we also had competency-based training, which was based on time scores. So in summary, I would say the key thing, the 2 biggest challenges in rural Africa for laparoscopy are 2 things: training and cost of minimal invasive surgery equipment. So that's why we have warmed up to the concept of GILS, of gasless, because it takes care of most of these issues that derail access to that. So thank you very much.
Thank you, Dr. Maura, for this insightful presentation about your current practices and also your interest in gasless laparoscopy and similar technologies to improve access in minimal invasive surgery. Quite a stark disparity between the uptake of laparoscopic surgery between rural setups of Kenya versus the urban. And I think probably it's a similar story in other LMICs as well when it comes to advanced technology. I'm sure people will have some questions for you, maybe at the discussion at the end of this workshop. And finally, for last speaker, Dr. Ganaraj, I would request him to upload his PowerPoint presentation. And it's a privilege to have him as the pioneer of modern day gasless laparoscopy introduction and training and implementation I think he's the leader who has set the scene and got rural surgeons trained in this technology. So over to you, Dr. Ganaraj.
Yeah. Thank you. I think way back in 1982, I went to work in a tribal area in North India, where about 250,000 people had no doctors. Coming from a premier medical college, I thought I was doing a great sacrifice by going there. I overheard one of the people saying that these guys don't have a job in South India. That's why they come to North India. Even here, they can't afford to stay in cities, so they come to this rural areas. Now, looking back over the last 4 decades, I thought God had wanted me to go and work in these rural and remote areas. And I can say that we trained about 64 hospitals in these rural and remote areas. And we started, as Biju said, the need for minimally invasive surgeries is really great. So even before we had the laparoscopy equipment, we used the cystoscope for doing diagnostic laparoscopies. And then in the year 2002, we started with ether and EMO machine for conventional laparoscopic surgeries. But then, even though the WHO figures is only about 60 to 70% of the LMIC hospitals do not have general anesthesia, our experience is that more than 80% of them do not have facilities for GA. So whatever we do has to be done under spinal anesthesia. So I became very interested in gasless surgeries. But during one of the ARSA conference, I saw Dr. Dakshinamurthy's device. But as you can see in the picture, it's quite a difficult one to use because of tenting and poor vision. And the exposure, which is similar to the conventional laparoscopy surgery, we're able to design the equipment which Stan in Coimbatore made for us. And for BMI less than 28, it is quite easy to use and there's hardly any difference in the visual capabilities, whether it is conventional or gasless laparoscopy surgeries. And we thank the Harvard and the Maulana Azad Medical College because they started the randomized control trial to compare gasless surgeries with the conventional laparoscopic surgeries. And their conclusion with it is not inferior. In fact, the physiological parameters are much better with the gasless. So we started having these gasless surgery workshop in several places, including medical colleges interested, rural hospitals, and some of the hospitals in fairly big towns also. So what is the impact of the various work that we have started? One was that, as Noel will share in the future, we started this target training program or proper training program, which Dr. Elijah said is necessary. And then we worked out that the proctorship or going to the rural surgeon's place to teach them is the ideal way of training the rural surgeons. Because of the 64 hospitals where we started MIS, most of them are able to actually continue to do those surgeries. We also started the certificate level course with the Martin Luther University accreditation and trained about 12 rural surgeons so far in gasless surgeries. And what has been the impact? We have done almost to more than 2,000 gasless laparoscopic surgeries. And if you look at the picture here, the surgical coverage, which Lancet says is about 5,000 per 100,000 population, which is necessary, we have been able to increase within 2 years to 3,700, which is quite significant. And now, thanks to the involvement of universities like University of Leeds, Delft, and Harvard, and organizations like IFRS, ARSA, GASOC, Institute, and so on, gasless surgery is gaining popularity. And we do hope this meeting would help us to get more popularity and be able to serve the population in rural areas. Thank you.
Thank you very much, Dr. Ganraj, for that lovely presentation and sharing your experiences and the evolution of the gasless device and its impact that it's had in the coverage of surgical diseases in the rural settings of Northeast India. I think we are running slightly late, so I would recommend that we move on to the next session and have the last session, the discussion time, to ask questions to our surgeons who have presented in the first panel. So I'll hand it over to Dr. Anurag Mishra. Thank you.